Hey, what's going on, everybody? Welcome back to Crash Cart Nursing, the podcast where we bridge the gap between nursing school and real bedside practice.
This is where we're going to talk about the things that are difficult to understand until you're actually at the bedside with your patients.
Yeah, today we got an episode where we're talking about vital signs and, more importantly, when they actually matter. Obviously, we always want to take those vitals, but we want to know, when are they important? When should be the high alert?
Yeah, when you're in school, we have you memorize all these numbers, what's normal, what's not. But the funny part is, in real life practice, those numbers don't actually give you the full picture.
So I've got a story that really kind of changed the way that I looked at vital signs. I'll never forget this patient, actually, because one of my good friends, who unfortunately is no longer with us, her name was Carrie. She was a great lady. She was a really, really great nurse. Awesome assessment skills, super bright, cheery kind of person. And she loved working triage, specifically walking people back to rooms because it got her steps in. And I'll never forget, because Carrie brought this patient back to me, and she's like, "Oh my God, Nick, this lady is just being a bitch." She's like, she's moody, she's irritable, she's just sighing at everybody. I mean, just super loud. And she's like, "We got people in the lobby, it's a busy day in the ER." And as soon as I walked into the room, I just knew immediately something was off. I smelled it first. It was that fruity odor. Really, I don't think ketones smell like fruit, but to me, they smell like, I just equate that same kind of flavor that it smells like when somebody's been drinking a lot, right? Because that is, they
like
leak ketones.
Acetone.
Yeah, acetone.
Smell.
To me, it's not really fruity. But once you smell it, or if somebody says they smell ketones, if you're a new nurse, I would encourage you, go in and smell. And I know you might feel weird, but go do it, because you got to learn that smell. And eventually you get to the point to where, like, they're in your department and you can smell it. You're like, "Oh, somebody's got ketones on the breath." So I was pretty alerted to this. I'm like, this is not irritation. And her huffy puffiness that my friend Carrie was talking about was not actually huffy puffiness. She was quite literally huffing and puffing because it was Kussmaul's respirations. And I immediately went and grabbed a blood glucose, and on my POCT glucose monitor, it said unreadable because it was so high, right? Just off the charts. And when we got that serum blood glucose back, her sugar was over 700.
Wow, that's a really high glucose.
Yeah,
the
so
highest you've ever seen?
I don't remember. It's hard to say. Everybody kind of blurs together. So if you're worried about me breaking HIPAA and talking about this, just know I don't remember anybody's names, and they all blur together. So I could be telling a slight confabulation of multiple stories mixed together.
Of just a bunch of
DKA. Yeah,
people.
Just a bunch of DKA patients all mishmashed together. So this patient was, in fact, in diabetic ketoacidosis. It means that their insulin isn't working, right? If they have type 2 diabetes, if they have type 1 diabetes, they're without insulin. So technically, can you go into diabetic ketoacidosis in type 2? Yes, but more commonly it is in type 1 diabetes. So they're not making enough insulin, which means no insulin means they're unable to use glucose for energy, for fat breakdown, and they start spilling ketones and they go into this metabolic acidosis.
I love diabetes, specifically DKA, right? Because that's kind of like, with my background being actually specifically medical ICU, we took care of DKA all the time. And so kind of this whole process of, like, usually with the type 1 diabetics, that's where you're going to see DKA compared to the type 2. Typically, we call that HHS, right? Slightly different pathologies, but borderline the same. I mean, we basically treat them the same. So this whole idea of, like, not having insulin, having your body will break down the fat for energy if it can't use the glucose that you're consuming, which obviously it's not actually the highest glucose I've ever seen, was like 1,300.
Holy moly.
Yeah, this person was comatose, and actually we got the sugar down and then they checked out AMA. So
love it.
Love that. But yeah, so you have that
See
fat
you next
breakdown.
time.
Right? Yes, and always found, like, in a gas station parking lot. It was great. Really solid MO, and honestly, I love that for them. So you have this fat breakdown, kind of the same thing as, like, eating keto, when you hear people say that they eat keto, they eat really low carbs, it's because they're actually trying to break down to use fat as energy. But anyway, I could go on
But
and
that
on
we go
about
into a
that,
different, as
right?
opposed to
Compared to
ketoacidosis,
ketoacidosis. Yes, ketoacidosis, emergency, right? Ketosis,
fat loss.
fat loss. And so you have kind of like this increase of ketones in your blood, right? Which is what gives you kind of like that fruity, acetone type smell, right? And typically they're doing those Kuzmal respirations. And so you can smell it actually. But then we call that, really what they're doing is they're now in metabolic acidosis. So like, what is that? When we talk about acid-base balance, our bodies, especially our kidneys are a fantastic organ. Actually, one of my sim groups just, I like went on a whole spiel about a nephron. It was great. If you're lucky, you'll get to hear me talk about nephrons.
Talk about the
Um,
nephron. Let's get it.
so like our body has this way of like regulating our acid base balance, which really just means like the pH of our blood. So normal pH 7.35 to 7.45. So anything within this range, ideally we want you to be as close to 7.4 as we can. It is what it is. But our body is really good at using our kidneys and our lungs, but we won't really talk about that today, to kind of like balance out this acid in our blood. So your normal pH 7.35, 7.45. And then in DKA, what ends up happening is ketones are very, very acidic. And so all of the bicarb that our kidneys are kind of like holding on to, and we use the bicarb to kind of like neutralize this acid that's in our blood, AKA ketones in diabetic ketoacidosis. And so what happens is we have like this really large drop in sodium bicarb, thus making our blood a little more acidic. When we actually, hopefully in a further episode, talk about the tic-tac-toe method and all of that.
Yeah.
Now we have a really low amount of bicarb. And so we're losing our body's natural ability to neutralize this acid in our blood, hence Kussmaul respirations, because we're trying to blow off CO2. Because it's like
Exactly.
an inverse relationship.
Yeah, it's like a teeter-totter, right? It's always, everything in the body is about homeostasis, right? Y'all have heard this word homeostasis as you go through nursing school. It's like the body is trying to find that regulation point where everything is even, everything's copacetic. And the problem is that when you have diagnosis like diabetes type 1 or diabetes type 2, we have different processes that can confabulate that, right? And kind of push it off to one side or the other. And the teeter-totter is going in that direction, and our body says, hey, I don't like this, so I'm going to do something to try to counteract it and bring it back into alignment. And we call that compensation. And compensation's great if your compensatory drive is working, but at a certain point your body says, hey, hold up, hold the phone, i'm not
Yeah.
gonna I'm not
I
gonna come
can't
back.
keep up with this.
I can't keep up, and it's not compatible with life, right, long term. Compensatory drive is great. You need to have it, but if you're always compensating, you got a problem.
Yeah. At some point, your body's going to say, listen, man, enough's enough. Like, I'm done.
Exactly. Exactly. And we see that manifest through vitals. So, vital signs in their most simple form are just showing us the ways our body's compensating. So, if your vitals are all normal straight across the board, normal is a washing machine setting, it's not a vital sign, right? So, when people just chart, oh, within normal limits, well, there's a big range of normal, right? And there can be normal for you, and there can be normal for the general population. But we want to make sure that we're taking into account what is actually good for your body's processes, what is your body used to, because that is going to be the differentiating factors. Really, our vitals, they're not just random numbers, they're all about that compensatory drive.
Right. And just on the off chance, right, that maybe you're thinking about going to nursing school, right? And you're kind of thinking, well, what even are vitals? Because that's really important. And actually, to kind of loop it back, right, to the last episode, easy, fundamental things, right, that if you don't know how to do them correctly, might lead to something else. So, vitals, right? We're talking about our blood pressure. We're talking about our heart rate, our O2 sats or O2 saturations for the full word. We're talking about
Yes,
actually
and they are
pain,
sats, not stats.
not stats. O2 sats. not stats. You won't be the only one saying that,
Are they
but
staturations or are they
we
saturations?
we're trying to set you up, right, for success
Yes. If you say
in
that,
your
it's
future
okay. We
career.
forgive you
For now.
for
Don't do it
now.
again.
Don't do it again.
So yeah, so we have our blood pressure, right? We have our heart rate, our O2 sats, saturations. We have pain, right? That's kind of an accepted label for pain now, is actually a vital sign because you really should be assessing that every time. And then we have respirations, which in my opinion is a very underrated vital sign. I feel like respirations can tell you a whole lot.
They do, for sure. And another term that you might hear when we're talking about vital signs is hemodynamics. So when we're talking about heart rate and blood pressure and perfusion, we're talking about hemodynamic stability versus instability. So we're looking at all of those different things. Our heart rate increases so that we can maintain cardiac output. So if we don't have enough cardiac output, you're not getting enough blood out to your body, out to your vital organs, your heart rate is going to increase, kind of tilting that teeter totter in the right direction because it's saying, hey, I don't have enough blood going out to all this stuff that's actually important. And then blood pressure is maintained until compensation fails. So when compensation fails, blood pressure drops off and the heart rate is going to try to compensate, but it can't. And then our respiratory rate increases in order to correct acidosis. So when we talk about this diabetic ketoacidosis, there is an acidosis that's going on, and so respiratory rate is going to go up, and that's why our patient starts breathing at a crazy amount, trying to blow off CO2 to fix the acidity in the pH.
I really love too that you just pointed out, because I just think compensatory bodily changes are so cool. I like when you start to really break down like the anatomy and physiology of it. I don't know if it's just a me thing. Our body is so good at doing this. And it's not even just with the kidneys or with the lungs or in relation to this acid base balance, but like with what you said about cardiac output. If you don't have enough fluid, not only do you have like that increase of your heart rate, but you also have like vasoconstriction and vasodilation and kind of all of these things that like happen in your body
Yeah,
without
it's
you
pretty
even
amazing.
realizing it. I mean, the human body is so cool. It's so cool.
The more that you get into this, so when you first start in nursing, you're like kind of compartmentalizing it all out. It's like, I got to learn about the cardiac system, and I have to learn about the kidneys, and I have to learn about the respiratory system, but they are all so interrelated. And so you have
Mhm.
to have a basic understanding so that you can start to put it all together. And that's kind of what we're aiming today at is how do we put these vital signs together, and it also involves lab values and it involves every different system of our body, like what's happening in each of these
Mhm.
systems of the body to try to fix a problem that was created because of a disease process like diabetes. So in this too, we also get into when we see big hemodynamic shifts, we also have these problems happen with infection as well. So sometimes it can get a little bit convoluted because we end up like first we start off we're talking about DKA, but I also want to touch on SIRS a little bit. So SIRS is systemic inflammatory response syndrome, and SIRS criteria includes elevated heart rate, respiratory rate, temperature, and an abnormal white blood cell count. And all of these are early signs of compensation, right? So um, if we can recognize these changes that happen with vitals, we can have a pretty good idea that something is going on, and it's either a systemic response to potentially an infection, some outside thing trying to harm the body, or it's because of a disease process.
Yeah. And because like we said earlier, right, your body is really phenomenal at bringing these changes in your vital signs, whether it's your heart rate, your respiratory rate, your blood pressure, until it's not. And actually, I had a SIRS alert happen. So normally when someone, even just to touch on what a SIRS alert is, so when someone comes in to the ED, because typically by the time they get to us, they've already kind of like hit these like boxes to be a SIRS alert. So normally, when you're inpatient, you don't quite get that because what happens is people come in, they're not feeling good, they're sick, um, And then once you start inputting all of these vitals into whatever electronic charting that you're using, it'll pop up with like this giant red box on somebody's chart that basically says, "Hey, this patient is a SIRS alert," and that kind of starts this whole process of like getting certain blood work, right? That's standard for the hospital, whether it's blood cultures, procalcitonins, D dimers, another white blood cell, kind of all of these things, getting
Lactic acid.
antibiotics.
Yeah.
Right. And so, but I did one time, and poor guy, I was orienting a brand new nurse who was already coming in straight to the ICU from nursing school, which is a whole nother
That's
ballgame.
hard.
He's honestly a great nurse now. Um, but second day as a nurse came in, and I remember us walking into one of our patients' rooms, and this specific patient was already kind of on our radar just because you don't really see a lot of young people in that, honestly, young people in general who are kind of coming in and flagging your nurse brain with, hey, something's kind of wrong here. And I remember myself and my orientee, like we walked in the room, and patient so nice, so pleasant, like talking to us, wasn't complaining about any pain or anything, but their heart rate was very slightly tacky, like a
Mm.
really, think like 101, 102, like just a little
Sure.
tacky, running a slight fever. Nothing that would normally make you say, oh, hey, that's an issue. But I remember thinking, huh, that's strange for what this patient has going on. Like they've been on a couple antibiotics, kind of gotten like those broad spectrum ones that we give just naturally, preventatively in the hospital. And we came in, we got report, we're talking to this patient, and then like 30 minutes later, now his heart rate's like 115. And his temperature is like maybe zero point 0.3 Celsius higher than it was. But now he's like, oh, I'm kind of having some pain. And he's getting, like a little aggravated, not even really aggravated. That's probably not the best word, but just a little restless, right? A little shifty in the
Sure.
bed. And within 2 hours, that patient was rushed to the OR, had severe, severe, severe peritonitis that none of us
Wow.
knew about. And actually, my orientee and I got to go into the OR. So,
Oh, that's
silver
sweet.
lining, it was a pretty cool experience.
Oh,
But
yeah.
within 2 hours, now we have this patient who was totally fine, barely, barely abnormal. And now he's tubed. He's on 12 drips, and the most popular person in the
Yeah.
ICU. And so it really happens quick, right?
It does happen quick. And with sepsis, it's so crazy because
Mm-hmm.
when somebody goes from having, like, maybe they come in and they've got a urinary tract infection, okay? And they're a little bit symptomatic, like they're painful with urine, maybe they have a little bit of hematuria, blood in the urine, foul odor, all those,
Mm-hmm.
classic signs and symptoms of a UTI. When you start treating them, it's kind of crazy because sometimes you give that first dose of IV antibiotics, and I swear to God, you start trying to kill the bacteria, and that bacteria, like just rages back at that patient, and all of a
Mm-hmm.
sudden, that patient that was stable, Mabel, is like, bam,
Is
heart rate's
like,
through the roof, blood
yep.
pressure's off the cliff, sats are off the cliff, everything looks terrible, they look bad, they have poor perfusion, you're seeing them clamp down, they're modeling in their hands and feet, and next thing you know, you're putting them on pressors, and if that doesn't work, you're intubating, you're continuing on pressors, and this patient that was stable Mabel with a mild infection is now ultra sick, and they're the most popular
Mm-hmm.
one in the hospital.
Right. And that's why it's so important to, if you're just looking at those vital signs, right? You're like, man, he's a little tacky. Nothing to be concerned about. Has a little bit of a fever, but he's barely febrile, right? Bodies are really great at compensating until they are not.
Correct.
So noticing these subtle changes, right, and kind of taking in this whole picture of the patient is literally in some circumstances like the difference between life and death. Not to make this, you know, really like
No, it's heavy, it's cool.
serious, but
But it
it
is
really
though.
is the difference between life and death.
Well, and I think too, like that's what we want you as nurses to be able to understand is like these are big things, and we got to be able to pick up on the little stuff. And like one of the things that I've seen pretty commonly is like, let's say you're in a care facility. You're not someplace where there's no really critical acute patients, right? Everybody is living at their home essentially, or you got some rehab patients who have recently come off of being acutely ill but are now just on the mend and trying to rehab their body. It's kind of interesting because when you have those patients, sometimes the trend starts like maybe they're somebody who's like chronically a little bit hypertensive. Maybe they're 140s over 90s, right, for blood pressure, and they're on meds, and but they kind of just live there. And you send a CNA to go take vitals on them. Maybe they get a once a shift vital sign, and they go to take a blood pressure, and they bring the vitals back to you, or they put them in their electronic health record, and you look at those vitals, and you're like, oh, Mr. Jones's blood pressure looks pretty great today. Like he's 125 over 70. Well, let's think about that for a second. He's normally 140 over 90. We have a 20-point diastolic drop, a 15-point systolic drop. How much do you need before that person is potentially having a vasovagal syncope? It's 20 points. Orthostatic hypotension can happen with a 20-point drop. So if we look at that through that scope, all of a sudden we're like, wow, maybe my patient is starting to show signs and symptoms of actually being unwell. So it's important to not just look at the value of that individual vital sign. Like you're like, hey, 125, that's great for a systolic pressure. But for them, why are they lower? Did we do something to make them lower? Are they dehydrated? Do they have infection brewing? And then you look at their heart rate, and their heart rate's gone up 20, 30 points. Like, guys, that should be sending alarm bells off in your head. Jazz hands.
Jazz hands.
That should be sending alarm bells off in your head that something is going on, that there's a problem where they are starting to decompensate. And then, they do get started on an antibiotic, their body might just fight back against that, And it can be pretty gnarly looking. They can get really sick really quick.
Yeah, exactly. And you see it all the time. So it's just kind of keep that as a little nursing pearl in the back of your mind
I
that
love it.
you just need to be very aware, right?
Yeah, and then we start talking about like other lab values. So obviously, we talked about you can get into your ABGs, and we'll get more into that in a separate video at some point where we really want to dive down deep because we know for nursing students especially and new nurses and even our seasoned nurses who don't deal with it very often, sometimes you got to do an ABG and you're just like, what the heck am I doing? I'm not a respiratory therapist. And when that goes on, like you want to be able to be smart, right? So you want to know how to do your tic-tac-toe and all that stuff, and we'd love to show you how to do that. And there's a million videos out there that show you how
They
to do
even
it, but
have
we're
a
going to go through it because it's nice to, put it out there, and maybe our voice is the one you hear. So we've got different things that we look at. We look at blood cultures, right? We're checking to see what is the bacteria that's growing, and how do we kill it. But then there's also other labs that we look at. You talked about procalcitonin, which is a good septic marker, and then another one is lactic acid. So I always like to talk about lactic acid with my students because I think that if you can understand this, you can understand vitals a little bit more clearly. So when the body doesn't get enough oxygen, it switches into anaerobic metabolism. Okay, so that means metabolism that doesn't require oxygen, right? Our body is basically being starved of that oxygen, and that produces lactic acid. So if you think about it, about working out, like if you've ever done a really tough workout, you go afterwards, you're not skipping leg day because you're not going to be that guy with no legs. And you get that burning feeling in your legs, in your butt, or you're doing a bunch of bench press, you feel a bunch of burning in your chest, right, in your biceps. All that burning feeling is lactic acid. Now, imagine that happening not just in those isolated muscles, but that happening everywhere throughout your entire body. That is what systemic hypoxia feels like. So when we have elevated lactate, it means that your tissues are starving of oxygen. It means that they're not getting enough, and they're going to do whatever they can to get enough. I remember watching different movies when you were a kid, and there's always a scene where, for whatever reason, people get trapped in a place where water is filling up and the oxygen is running out. I think the movie Tangled has a scene like that where Flynn Rider and Rapunzel are chilling out, and the thing is filling up with water and they can't get out. And She's got to use her magic hair to glow, whatever. Anyway, Disney data here. But anyway, so you're that's kind of what happens when we are in lactic acidosis. So our body is needing oxygen. It is deprived of oxygen. But the problem is that it doesn't have a way of getting that oxygen. And so it does have lactic acid buildup. So your body can't manufacture oxygen, but it can manufacture lactic acid, which helps in some cases, in some parts, right? So we need that lactic acid so we can recover. And there's things that it's good for, but it's not good at a systemic level when we have an overload of lactic acid. And so it's that same thing where all of a sudden, if you're Flynn Rider and you're underneath the water and you're trying to go and open the valve up so that it'll drain the water out of the room so that you can breathe again, imagine your muscles trying to fire and doing that without oxygen. It's hard, and that's what your body is doing at a cellular level. Is it's like, I'm without oxygen and I'm trying to make this happen until eventually it just catastrophically fails. So it's just a really good visualization of what does lactic acidosis look like. And here's the thing. If you can understand that concept of what it's like to work out and do something without oxygen, that's essentially what's happening when we're having this compensatory drive take place in DKA or in SIRS, is that the body is just trying to compensate when it's at a time without oxygen and it's gone into that anaerobic metabolism. What kind of goes through your mind when you're getting like a really sick patient from the ER who is maybe in SIRS or DKA? Is there ever just like a, oh God, what did they not take care of moment? Or like, how do you think about it as an ICU nurse?
That's actually a really great question. So I will tell you the one thing coming from an ICU nurse, if we're getting a patient who came into the ED is now prompting a SIRS alert, or they're kind of past that point where they didn't come in until they were now actively septic. And so we're fighting against that process. As far as getting them set in that standard treatment and kind of like activation of a SIRS alert. So drawing your rainbow, drawing your blood cultures, giving those broad spectrum antibiotics, right? If a patient's really sick, getting them tubed and just stabilizing them as stable as you can possibly get them, and then bringing them to us to now get them settled with if they're needing pressors, right? Or putting them on a bicarb drip or kind of those things that we'll end up doing depending on the scenario. You guys are really good at that. What what would make me say as an ICU nurse is, why are your lines tangled?
Oh,
And why are they not labeled? Do you know how
well,
hard it is?
well, listen here, okay? This is actually a conversation that I've had many a time, and it usually goes something like this. Listen here, motherfucker. When they came in, they did not have a label on them that said what was wrong with them. We didn't know what their name was. They came in with no pants, no shirt, and most places would say no shoes, no shirt, no service, and we're like, yeah, let's figure out what's wrong with you.
Come in straight up naked, and we'll
Yeah,
still
straight
we'll still
up,
take care of you. It's fine.
straight up naked, smelling like alcohol, covered in vomit, GI bleed, whatever, because that's how it is in the real world. So like, we have these patients that like I say it crudely, right? But they just don't have the label on them. We don't know what's wrong with them, and they didn't have any lines in them when they got to us. They didn't have anything. And sometimes they're combative, sometimes they're off their rocker, but they're just sick, right? And they need help. So I think that that's one of the big disparities between ICU and ER is I'm like, they're like, what did their skin look like? I'm like, they are wearing it, man.
No, I will tell you, I am an ICU nurse that is like, especially when I orient, I'm like, don't ask them about their skin.
Yeah, just
They're
don't.
not going to know. Just don't
Unless
ask
they
them.
came in for a skin condition. I didn't look. Like, they have it
Right.
on. It's still there. They're
Right.
wearing skin.
They're wearing skin. I am usually, me personally, right? I like to think I'm like the chill ICU nurse. You know what I mean?
For sure.
But I'm usually more concerned with like, how much oxygen are they wearing, right?
Yes.
What's even going on with them, and what did you do? Like after that, I can usually figure it out. Another one, I'm gonna take the time to tell you that this is a
Tell
big
me.
gripe for me, is don't tell me, well, they were clean when we left the ED, and then they show up, and that is very
Do
obviously
you
an
know why that
hours
happens?
old
Do you
bowel
know why that
movement.
happens? Okay, they
I know you're
sometimes.
doing it on purpose. I know
Oh,
it.
absolutely, absolutely. No, we're not doing it on purpose. No,
Like,
but you know what
that did not
happens?
happen in the elevator on the way here.
I don't know of any timestamp on that. There's no way to tell that. That's hearsay. No, but you know what it is that like we're busy. We're not one to one a lot of the time. So a lot of emergency departments they do not have that opportune staffing like we talked about in our last episode of like I came from a facility that was like awesome. The staffing is like you if you have a critical patient you have a float who's going to either
Hmm.
take your patients or take the critical so that they can really focus all that time in a lot of ERs. And I saw this during COVID. I went and I did a little bit of travel, albeit local travel, to make that money. I'd have like two or three critical patients at the same time and you're trying to float between them, and they're
Hmm.
not stable critical patients, they're unstable critical patients. It's like, hey, this guy got has a gunshot wound to the chest, and we've done plain films. He needs his IV access and to be sent to CT scan, and like you're like, wow, thank you so much for that. And I already had a patient that we just intubated. And like I'm still trying to catch my tail. So that is a reality in a lot of places of like, it's just a staffing issue and it's not ideal and it's not great. And honestly, we need to push for better. If you're a
Hmm.
charge nurse, you need to advocate for better staffing for your people, because that's how we get burnout for one, but two, it's how we create unsafe places, unsafe ratios for our patients, and that's a big thing. So, like as a charge nurse, it's your job to step up and say something about that. So, the other thing that does happen, and I will admit to this, is if I've got a patient that you know maybe they come in and have hepatic encephalopathy and they need that lactulose, like, homie, I'm
I
not
know
gonna
you're gonna
lie.
give it right
I'm gonna
before
give
we
it
do that
as
too.
I'm gonna give it as they're leaving, and so that might hit the bed. If you don't know, lactulose helps you get rid of excessive liver toxicity. So ammonia, as we're trying to excrete that bilirubin and ammonia, the only way to get rid of it is to have a bowel movement, and so we give them lactulose, and it will make them go. It will
It
make them
does.
go pretty quick, and it's usually diarrhea. But that's how we get them cleared. That's how we get their mental status improved, because their liver needs to function.
Yeah.
So
Yeah.
I'm sorry to
I
all the ICU nurses out there. I'm sorry. I did, in fact, give them the lactulose right before we left the room to come up to the ICU.
You know what? Honestly, it's not even like the poop, cause whatever, right? I
Yeah.
don't care if the
Everybody
patient shit the
poops.
bed. Like everybody poops. It's fine. It's normal. Don't shame people for it. It's the insulting my intelligence part that I think really drives that like, ugh, really? You're gonna tell me that that happened on the elevator on the way down here?
Hey, if you want to have a debate like this, we got to get somebody
Uh,
from lab to talk about our specimens that they say were
my
hemolyzed,
God.
because
Yes.
that's a common enemy, right? Like,
Yeah, I know that they weren't hemolyzed.
yeah, it was not. And you
It
know
was
what?
not.
I actually have a friend who's in lab, and she was telling me, she goes, sometimes we just drop the specimen, and
Dude, yes.
and I'm
And
like,
that's
so why
fine.
don't you just own it, man? Just say that you dropped it, because you're gaslighting me into saying
Yeah.
it's my fault with the draw. And I'm like,
Yeah.
listen, you know,
Like that I drew this out of a femoral art line.
for
I
real.
know that this is not hemolyzed.
Oh my gosh. So I got to
Oh
tell
my
you,
God.
talking about femoral art lines, so really coincides well with what we're talking about, this hemodynamic stability. So I was working on this patient one time that came in, and she's septic and she needed a central line. She was a really difficult stick. I think we had put in a couple ultrasound lines into her, but they were just
Hmm.
her veins kept blowing out. They're really small, couldn't handle anything, and we knew we were going to need pressors on this girl. So it's like we
Right.
got to put in a central line. So I go to my ER doctor and I'm like, hey doc, I think we need to put in a central line for this lady before she deteriorates. It's probably going to be a lot easier to do it now than if we wait till she's super sick. And he's like, you know what? I agree completely. Let's go ahead and do it. So we go in and he's putting in a internal jugular central line. Misses it, can't get it. He's like, dang it. Well, he's like, I'll just do a subclavian. So he goes to put the subclavian, and he can't get the subclavian either. So we're two central lines in. And if you know, a central line is a sterile procedure, and they're not quick, right? Like, I mean, some docs are pretty quick at them, but it does take some time out of the day for the ER doc, and time out of the day if you're the ER nurse working with that patient, or the ICU nurse, because they put central lines in all these critical patients. And so the patient is alert and oriented, but she's pretty quiet, like the whole time that this is going on. And she was just going with it, like she knew she was really sick, but she didn't really say a whole lot, like the whole time.
Yeah.
And so he's like, gosh dang it. He's like, we got to put in a femoral line. He's like, I'm just going to put in a femoral line. And the femoral line was horrible to get in, but he got it in. And he's like, well, I'm not going to lie, that was a little bit less than sterile. But it's in, he's like, we'll cover her with antibiotics. Like, he did his best, but it was just a really tough placement.
Sticks,
yeah.
Man.
Hard sticks.
And femoral lines are already hard to put in.
And you're in a
anyway.
dirty
like
place, right?
Yeah.
For most people, right? And that's a body habitus thing. Like, it's just, it doesn't matter how clean you are, like in your groin area, it's not going to be the cleanest place to put those. And so, but he says the funniest thing. He goes, well, I mean, all things considered, she doesn't look like complete dog shit right in front of the patient. And I'm like, and she looks at me and she goes, what? like, just like, that was literally her. She's like, what? And I'm like, what he meant to say was that all things considered, you look pretty great. Like, your vitals are not great, but like, and you're very sick, you're septic, but you're still alert and following commands and all this stuff. And I think it was one of those lapses of like, I forget where I'm at right now.
Yeah. Listen, I can't speak for everyone. That would make me feel so much more comfortable with my doctor.
I agree. I'm like, I prefer them to act like humans. And we are humans, right? So like, I don't know. I guess I want people to know, like, we're not out there just like making fun of people, and I don't ever want my patients to feel like we're making fun of them. We do make fun of funny things that happen, but it's not making fun of them. And so sometimes we gotta watch what we say when we say it. You gotta know your audience. But I'll never forget that. It was so funny.
Extra emphasis on please know your audience. I've definitely put foot in mouth a couple times.
I have a disorder, foot and mouth. I say things that I should not say. I'm a habitual line stepper. As an ICU nurse who's taken care of like lots of critically ill patients over the years, tell me, like, what are some mistakes that people make, and how do we avoid those?
Yeah, I think one of the big ones, honestly, is just not trusting your gut. I can think of a story one time where I kind of the same situation, actually, a little crazy. Younger patient, really no significant health history. Honestly, it was probably because a lot of young people don't go right to the hospital or to the doctor, and so there's just nothing there, but was a dialysis patient. They were with us just because they weren't looking great. Soft pressures, and what I mean by soft pressure is that their MAP is still adequate, right? The MAP is still above 65. They're still
mean arterial pressure
tissues.
for anybody who doesn't know.
Oh yeah, mean arterial pressure, and really anything above 65, you're still perfusing your tissues. But they, if they like to have a closer watch to you when you're kind of riding that line of not having a super great MAP. And we had been taking the blood pressure on the left arm, right? Because in the ICU, we can hook you up to the space labs, set whatever interval we want to take your blood pressures. And the blood pressure started trending down. And you do kind of do this like nurse thing, right? Where you're like, oh, let me check the other arm just to see. And the other arm was a lot higher, right? But the patient was also kind of looking still oriented, slightly more lethargic, like minuscule, barely perceivable amount of lethargy in this patient. And so, but we had been getting good blood pressures on this arm for a while. And now we're kind of starting to see like this trend down. And I remember I went and I talked to, it was actually the resident at the time. So the attending doctor wasn't even there. And one of the things you'll notice that doctors will ask you, right, what are their vital signs? And so I'm explaining to the resident, I'm like, well, the blood pressure is kind of starting to trend down. Like we've been taking it on this arm. I'm not really concerned that the blood pressure is inaccurate because we've been getting accurate results, right? And so the resident called the attending, who didn't come and actually look at this patient, but we won't get into that.
Story for another day.
And the response from the attending was, well, did you take it on another extremity? I'm like, yes, I took it on the other arm, and it's still like not really acceptable. It's a little higher, but we're still seeing like this trend down. And they responded to me, take it on the leg. No. No, I need you to come and look at this patient. I need
Right.
blood work, right? We need new blood work. And I hate to say it, but this particular physician was, how can I say this? And so a little more laissez-faire. I think that's the word I'm going to use. A little more like, it's fine, more reactive rather than proactive. And I was just like, no, I'm not going to take it on the leg. We've been taking it,
For
on
sure.
the same arm. It's
You're like,
like
we have
you
data.
need, yes, right? How can you tell me that all of these blood pressures previously, right, are acceptable, but now that it's low and now that I'm calling you because I feel like there's an intervention, you're gonna tell me just to take it on the leg. I did it just because you know, slight pecking order. I'm like, it was okay. And he's like, well, we're going to use that one. And I'm like, no, we're not. You need to come and you need to look at this patient because there are slight, cognitive changes,
Sure.
and even though it's still okay, like we're seeing this downtrend, um, ended up coming, right, and actually looking at the patient and was like, you know what, you're right. Let's order
Go
some blood
figure.
work, all of these things. And the patient actually ended up going septic.
Yeah.
So the big thing with this story is I want to really encourage you to trust your gut, right? Each part of the interdisciplinary team. So no part of the team is inherently better than the other, right? As a nurse, though, you are the one who is with the patient, and you are the one who is seeing the patient and really, really looking at these trends, and kind of this whole idea of what we've been talking about today is vital signs are great and it's good to know when they're normal, but seeing these kind of subtle changes and changes in trends, right, and changes in other aspects of your assessment really, really make the difference of like being able to catch things early. And so I don't really know what would have happened to this patient if I just hadn't trusted my gut and been like, nope, something is really wrong. Like I
Yeah, it's this idea of that we have to be smart, for one.
mm-hmm.
You got to be a critical thinker, and then you have to be able to be assertive. Because physicians are not always going to just do what you ask for. Give them data. They want data. The medical field is very data driven. So a big thing is if you notice that somebody is deteriorating or you think that they're deteriorating, you need to first get as much data as you can get with the orders that you already have. So most of the time that's just vitals and knowing what they are, but also looking at the trend. What did the trend look like? Because it is really, really important. If they have a 30-point drop in their systolic blood pressure, or their heart rate normally lives in the 90s and now they're in the 50s, what is going on? They have something happening. So you want to have that data and take it to them. But we also want to make sure we've troubleshooted our equipment, right? So I don't care if somebody has a low blood pressure if the blood pressure cuff is on incorrectly. So what Courtney's talking about is like if that blood pressure cuff wasn't applied correctly, that's what they want to know. Are we sure that this is accurate? Or is it a one-off where somebody put on the wrong size cuff? Maybe your aide took the blood pressure. Not to say that the aides are not competent enough to take a blood pressure, because we train them, but sometimes there might have been something that happened. Maybe the blood pressure cuff that was appropriately sized broke, or maybe, whatever. Maybe they're using different equipment than what they used before. So it's making sure that we're troubleshooting the equipment, using the equipment correctly. We want to make, and then does the clinical picture of this patient match what their vital signs are? So if somebody has high heart rate, low blood pressure, and their oxygen sat's low, I might expect to see some cyanosis. They're going to start turning blue because they're not getting enough oxygen. they're not perfusing well. What's the rest of the picture look like? And the more that we can take that to the provider and give them real objective data, the more likely they are to listen to us. I wish they would always just listen, but that's a work in that's a work in
That
process.
is a work in progress.
And I will tell you that I feel like that this is a paradigm that is changing, because when I started in nursing over 10 years ago, we had doctors that were like, "Don't you dare call me in the middle of the night," you know. Well, you're on call, sir. Who am I supposed to call if you're not going to
Yes.
take the phone call? Scream at you and hang up the phone. And I don't see that as much happening anymore in medicine. I think there are still outliers. There are still those kind of people. But I think in general, like if you talk to new physicians coming out of medical school,
Yeah.
if you talk to new residents, if you talk to new attending physicians who have just come up through the ranks, we do see that paradigm shifting to where it's like, hey, nursing is a valued licensure to have on our team, and we want to listen to what they say. We have really good representation when it comes to in the community, in in TV shows and things like that, showing nursing in a really good light. We are a respected profession. And the reason we're respected is because we have consistent education. The reason we're respected is because we have standard ways of doing things, and we adopted ways of communicating with providers. So you might think, oh, giving an S-bar, that's so annoying. It's a standardized communication that was started in the military, and it's there for a reason. And it's an effective way of communicating with people who are superior, or even people who just need to be involved with the situation, and really giving them a concise version of events is super important when we do that. And when we do those things, it makes us be more respected. So if you go to that doctor and you don't have rapport with them, if you go to them and you have actual details, actual objective findings, they are way more apt to listen than if you go to them and they're like, well, what are their vitals? And you're like, I don't know, I did not take them. Well, a prudent nurse is going to go and take a set of vitals. They're going to assess the patient. They're going to do those things before they call the provider. And then my biggest pet peeve is not checking the orders to see if you have something. Don't call the doctor for a PRN order for something and then realize it's in the orders already. That is a way to get your head bit off by the provider. If you call them at 2:00 in the morning for something that you already have an order for, I guarantee you're getting yelled at, and let's be honest, you deserve it.
Do you want to hear something so embarrassing that's related to that? Oh my God. When I was in when I was a new nurse, oh my God, I can't even believe I was saying this out loud. I actually called a doctor at 2 a.m. I called a surgeon, mind
Heck
you,
yeah.
at 2 a.m. to to ask for dressing change orders.
Yeah.
Isn't that, oh my God.
Well, so I mean, when we're in nursing
That
school,
was
one of
not
the
a
things
pleasant
we
phone
always
call.
we're always like, you have to have an order for everything, right? You have to have an order for everything. And some surgeons don't want you to mess with their stuff, right? So if they're fresh post-op, they're like, I will change the dressing the first time. Well, what if it's leaking through? Reinforce it, add more stuff to it. If you do have to replace, though, replace with whatever was there.
Right.
Just look at it and reverse manufacture it.
Right.
You know what?
Try
I
to
know
use all of
people.
your resources.
I know people have called for a stool softener at 2 in the morning. They're constipated right now. Guess what? They're still going to be constipated in the morning.
Yeah, right. And guess what? You're not a bad nurse for doing that.
For sure. And
Because
if
you're
they're
just
on
trying
call,
to do your job and they're on call, but
exactly.
maybe loop in your charge nurse. That's why we like you to do that.
Yes.
Because maybe we can fix it for you. But I
It's
did
funny
do
because I think when people are new that they don't even know the resources that they have. And so we drill so much in their head. It's like, call the provider, call the provider. Is what you're asking for something that somebody else might be able to answer the question for you? And it's never going to be the bad idea to just be like, hey, charge nurse, I'm new. I see this going on. Would you recommend I call the provider right now? And see what they say. Because there might be a protocol that you don't know about. There might be a way of
Right.
doing things that you don't know about. Your facility has its own guidelines. So just it's okay to be new. It's okay to get it wrong. And if you do end up calling the provider, you might get yelled at, but ultimately you're going to learn from it. And we learn from the bad things too. So just always be open to learning, whether it's from the great experiences you have with somebody or more often from the little falls Those are the things that help you.
Right. It just takes practice. We've all been there, right? If a nurse tells you that they've never made a mistake, they're lying, or it's their first week on the
Yeah.
job.
Or it's too much
We've all
pride,
done it.
right? Too much pride that they
Mm-hmm.
won't admit that they've made mistakes. I think that, like, one of the things that makes you a strong nurse or a strong person in general is that when you can figure out how to be better based on your mistakes. So
Right.
that's super helpful. So, as far as some tips, what are some tips that people can do to help them with vital signs, or to make sure that we're not chaos calling the doctor, in a panic? What can we do, Courtney?
So, besides trust your gut, right? Look at your patient, you know? If your blood pressure is reading something, say it's, I don't know, 40 over dead. If your patient's talking to you,
They're probably not that.
make probably not that. There's never any harm to readjusting your blood pressure cuff, grabbing a new one, right? Making sure it's the same, making sure it's the correct size. Or if you're seeing funky, on your EKG machine, right? Like the heart rhythm doesn't look quite right. To what you're expecting when you're in there and you're assessing your patient. Make sure you don't have your wires crossed. So just making sure that you're using your equipment correctly, taking just that extra second, right, to confirm that it's on
Yeah.
correctly, it's working correctly, and then really just compare it to their baseline. If you have someone who, say, has had a stroke, right, so they've got some deficits with their vasculature. Sometimes they might run a little lower on their blood pressure or hypotensive at baseline. So even though as a nursing student and you're in school, our normal blood pressure is like in that 120 over 70, 120 over 80 range. If someone's, 88 over 50, that's okay because that might be their baseline. So
Right.
doing your due diligence, kind of digging in the chart, seeing what they've been at, can save you a lot of headache and a lot of added stress that you might not need to
Yes.
take.
Yes. So don't just rely on those numbers. And then the other thing too, though, is like, if you're in looking at a patient and they look bad, and maybe another staff member has collected their vitals, and like you're seeing a 16 or an 18 for respirations, and you go in and you look at them and you're like, wow, they're kind of huffing and puffing away. Count the respirations yourself. You know what I'm saying? Take a pulse, feel it. What does it feel like if all of a sudden, or maybe if it's like an epic where their heart rate is automatically pulling over to the computer, right? Based off of the Space Labs reading, or whatever system that you have, if it's pulling over automatically and all of a sudden you see a range that, like a heart rate or a blood pressure that's way out of normal, maybe go and check a manual blood pressure, check a
Mm-hmm.
manual pulse, like actually palpate a pulse. Are they going in and out of AFib? What time was it at? Can you go back and can you look at the heart rate and see, did they have some kind of event at that time that was going on? Or was it something where it was like they moved out of bed, the sticker came off, and then it got resituated, and the computer happened to capture that number, but it's not really an accurate number. So we just want to make sure that those kind of things are real that we're putting in there. Or you see a number that it's like, oh, they have a heart rate of 12 that the staff member put in, and then you realize that somebody fat fingered it and it was supposed to be 92 or whatever, but they hit the wrong key as a keystroke error. Those kind of things we want to look for. But yeah, ultimately trust your gut. If you see something that is off, get a second set of eyes to come and look, whether that's a charge nurse or a crisis nurse or just a peer, to come and look at the patient. Hey, will you come and look at them? They don't look so hot, and I'm worried. I just want to make sure that I'm not missing something. I think that knowledge sharing, that asking for a second set of eyes, is never a bad thing.
Right. I guess that just kind of comes with practice too, because we
Yep.
do kind of drill in you like memorize this normal, memorize all of these numbers, but um, kind of crossing that line now from being what would be considered like a novice nurse into now
Mm-hmm.
being a nurse that has some experience is starting to incorporate like those patterns that you're seeing. So that's where nursing school is going to teach you, how to pass the NCLEX, but as you get into the world, right, then it's a little more all encompassing than just recognizing the numbers.
Absolutely. It's not about us memorizing numbers. It's about recognizing patterns. It's about seeing between the lines the different things that are not super overt. And that's all the stuff that comes with experience and it comes with time. And you're going to get there. So don't feel like you're dumb if you're not there today. You're just in this state of learning. You're in this state of growth. And it's going to get better with time. Your assessment's going to get better with time. You're a work in progress. And that's why we call it nursing practice.
Exactly. Practice, not perform. Well, that's all we have for you guys today. So thanks for hanging out with us while Nick and I talk about some of these crucial nursing skills. Please like, subscribe, repost all of these videos, tell your friends about it, tell your family about it, right? Have a watch party. Amazing.
Oh man.
Because we're really trying to kind of reach out, right, to anyone who could potentially benefit from this. On that note, if you didn't enjoy it, forget you even listened to it. Okay, we just won't.
We already forgot about you.
Yeah, we just won't ever talk about it again. But thanks for giving us the view. Either way.
Yeah, thanks for coming, guys. See you next time.